Hello and welcome to the next sections of pharmacokinetic, that is excretions. We have already covered absorptions, distribution, metabolism. So now we are heading to fourth aspect, that is excretion in pharmacokinetics. Now excretion is basically passing out of a drug from the body, and excretion of drug happens with different routes, and the most important route is urine. Most of the drug gets excreted through the urine. But you need to remember few drugs which are excreted through feces as well. These are the drugs which undergoes enterohepatic circulation, like erythromycin, ampicillin, rifampicin, and tetracycline. These are some of the antimicrobial drugs which excrete through the feces, and important is oral contraceptive pills. These drugs also get excreted through the feces. Drugs also get excreted through air, especially from exhalation. These are general anesthetics, mostly gaseous forms, and alcohol. We know that breath test is been done to detect the level of alcohol in exhaled air. Drugs also get excreted into sweat and saliva, and the important example is rifampicin. Rifampicin gets excreted into the urine as well as into the into the sweat, and because of that the discoloration of sweat can occur. Other drugs which can excrete to saliva and sweat are lithium and heavy metals. Drugs also get secreted into the milk, and through which the babies can get exposed to the drugs. So we need to remember which drugs gets secreted into the breast milk. Now renal excretion, which is the most important aspect of excretion, that excretion through the kidney, involves three main things. First, glomerular filtration, tubular reabsorptions, and tubular secretions. Let's see in detail about glomerular filtrations. Now it involves filtration, means it's a simple process of filtration through glomerulus, where the heavy molecular weight substances gets filtered out and the non-protein bound free drug goes into the tubules. So glomerular capillaries have pores through which drugs get filtered out, especially the non-protein bound drugs, as we have already seen in plasma protein binding, that free drugs only gets access to the metabolism and excretions. This filtration depends upon blood flow as well, and we already know that any filter, if they need to work in a better way, the filtration pressure should be enough. So good blood flow, good filtration pressure is always a main thing which maintains the glomerular filtrations. Normally GFR is about 120 ml per minute, and with decline of age and any renal pathology, this filtration decreases. Next comes tubular reabsorptions. Now we have already seen glomerular filtrations, then we are going to the tubules, and in this renal tubules two processes going on. One, secretion of molecules or ions inside the tubules, and second, the reabsorptions of important molecules in the body. So we are talking about reabsorptions. This reabsorption process is mainly of passive diffusion type, means it's mainly depend on two things: lipid solubility and ionizations. Now where we have seen these concepts of lipid solubility and ionizations? Yes, in absorption portion. So again this reabsorption is also similar to the absorption, so all the fundamentals related to lipid solubility and ionization applies here. So let's take a clinical significance from that. For an example, if the drug is acidic in nature and if urine is basic in nature, now what happens to drug? The drug becomes ionized and there would be decreased reabsorption of that drug, right? So this is the concept we are using in the case of toxicities or poisoning. If patient taking more of an acidic drug, for an example barbiturate or salicylates, what we need to do? Should we alkalinize the urine or acidify the urine? Yes, we need to alkalinize the urine and make the urine basic so that drug gets ionized and gets less reabsorbed. Same way, what if the drug is basic in nature? What we need to do? We need to acidify the urine so that again drug gets ionized and less reabsorption occurs. And this basic drug poisoning are cases of morphine and amphetamine. So this is a clinical significance of this reabsorption system. And the third important thing is tubular secretions. We have seen that in tubules, two processes been going on, tubular reabsorptions as well as tubular secretions. Secretions means these drugs or the molecules or the ions get secreted into the tubules, and this secretions occurs through different transporters or the pumps. Some are organic acid transporters and base transporters. Now, which drugs get excreted or secreted through acid transporters? These are mostly acidic drugs like penicillin, proban acid, uric acid, and salicylates. And the basic transporter mainly secretes diuretic drugs that we will see in CVS aspects. Again, what is the clinical significance of it? So we are taking one example so that we can understand the clinical significance of this secretion portion. A drug proban acid is given with antimicrobial drug penicillin. So why they are combining proban acid with penicillin? That is the main thing. The answer lies in the secretions. Now this is a tubule and this is a pump. This pump secretes the penicillin in the tubules and reabsorbs uric acid in the body. This pump is known as organic acid transporter pump. What if we inhibit this pump or block this pump? The penicillin won't get secreted into the tubules, so the concentration of penicillin increases in the blood, so there will be longer action of penicillin in the body, and the uric acid reabsorption won't occur, so uric acid will get lost from the body, decreases in the body, and that would be helpful. So two help occurs with the help of inhibiting these acid transporters. One, we are achieving higher concentration of penicillin in the body, and second, we are decreasing the uric acid level in the body. So clinically, two advantages are there: high level of antimicrobial that would be help in treating the bacterial infections, and decreased level of uric acid that would be helpful in gout. And this inhibition can occur with the help of drugs like proban acid. So this is the clinical significance of secretions, right? There are many examples, but this is one of the best example through which we can understand the significance of tubular secretions. So now we are into the kinetics of eliminations, and this is most important part of excretions. It starts with clearance. We need to understand what clearance is. So clearance is basically, as the name suggests, we need to clear. But what? We need to clear the plasma from the drug in unit of time. So clearance is a theoretical volume of a plasma which is cleared of drug in particular unit of time, and the formula of the clearance is rate of eliminations upon plasma concentration. So this is how you can calculate the different MCQs or in practicals about this clearance. You might be given a figure of rate of eliminations and plasma concentration, and you would be asked to find out the clearance of drug. So this is how you can use the formula. The important aspect of this excretion is the drug which follows the kinetics. This is excretion kinetics, means by which way drugs gets eliminated from the body. So depending upon the drug, a particular characteristic is associated with it. Like most of the drugs follows first order kinetic, while very few, like for an example alcohol here, follows zero order kinetic. Now what is the difference between this first order kinetic and zero order kinetic? Let's understand by a important clinical scenario. For an example, a patient has taken 1000 mg of drug here. After, you can say, 1 hour, the concentration in the blood decreases to 500 mg. After 1 hour, it decreases to 250 mg. After 1 hour, it decreases to around 125 mg. After 1 hour, it decreases to around 60, and then after 1 hour, it reaches to around 30. While in different scenario, or next scenario, where patient takes same 1000 mg of drugs, after 1 hour, the concentration on blood decreases to 950 mg. After 1 hour, the concentration is in blood is 900 mg. After 1 hour, it's 850. After 1 hour, it's 800, and after 1 hour is 750 mg. So after 5 hours, in this scenario, the concentration is just 30 mg around. And in this case, after 5 hours, the concentration of drug is still 750 mg. So what is the difference between these two scenarios? Here, the 50% of drug gets eliminated at every hour. You see, 50% of this 1000, 50% of this 500. While here, 50 mg is getting eliminated every hour. You see, so here you can say constant fraction is getting eliminated, while here constant amount is getting eliminated. So this is a difference between first order kinetics and zero order kinetics. So it's been written here that in first order kinetic, constant fraction is eliminated per unit of time, and here the constant amount is eliminated per unit of time. Now let's take one more example. For an example, same patient now has tried to commit a suicide, and he has taken more drugs. He has just taken the double the dose. So 2000 mg of dose patient has taken. So after 1 hour, in this case it would be 1000 mg. After again 1 hour, it would be 500, and eventually so on, it will reach to 30 mg, right? So it will take 1, 2, 3, 4, 5, and 6 hours it will take to reach the 30 mg. So almost all the drug gets eliminated, you can say, here in within 6 hours. Now what happens here? If patient takes same drug in double the concentrations, so now after 1 hour, it's 1950, then 1900, then 1850, then 1800, and 1750. See, so after 5 hours, it is still 1750 concentration there in the body, while here almost all gets out of the body. So you see, the clinical scenario is here in first order kinetic, if we increase the concentration, there would be simultaneously increase the excretion of the drug. So rate of elimination also increases if you increase the concentration. While here in zero order kinetic, if you increase the concentration, will rate of elimination increases? No, there is more accumulation of drug here. So that is why zero order drugs which follows the zero order kinetic, they are very dangerous, and you need to keep the concentration in limit. So that applies to alcohol. If patient is taking alcohol in normal range, that is okay. But if the concentration rises, the kidney is not capable of keeping the drug out at the same rate. Now the drug will get accumulated, and there are chances of side effects, toxicity, and patient might go under the coma. So drugs which follow zero order kinetics are very dangerous, and you need to keep those clinical scenario in mind. Here in first, so the same thing has been written. Rate of elimination here is directly proportional to concentration, while rate of elimination is not proportional to the concentrations. Here the clearance remains constant, because if you increase the concentration, that would be same time increase the rate of elimination, so clearance will remain constant. While here, if you increase the concentration, there is no increase in the rate of eliminations, so clearance of drug decreases and there is more accumulation of drugs. T half we'll see in the next portion. The T half also remains the constant. Means if you increase the concentrations, the time T half means time to decrease the concentration to half of its original value. So T half here remains constant, while here you need more time to decrease the concentration to half of its original value. So T half here increases. Zero order kinetic is also called as capacity limited eliminations or Michaelis Menten. What is mixed order kinetic? It's a combination of both of these. Normally, the drug follows first order kinetic, but when the concentration increases, it follows zero order kinetics. So drugs like phenytoin, which is used as an anti-epileptic agent, tolbutamide, which is being used as an anti-diabetic drug, theophylline we use in COPD, warfarin we use in anticoagulant as therapy. All these drugs follows mixed order kinetics. So if we increase their concentration, there are chances that your kidney is not eliminating drugs in a same manner, right? So it becomes very dangerous if the concentration of these drugs increases inside the body. Now let's jump to the next aspect of elimination, and that is plasma half-life. And we have seen the time taken for drug to reach half of its concentration from the original. So if the original concentration is, for an example, 500 mg, and now it reaches to 250 mg, so the time taken for it is called as half-life. So it's been generally said in first order kinetic that nearly 50% drug gets eliminated after first half-life, because half-life, it means suggests that 50% drugs is decreased. Again, after second half-life, half of the 50, so that is 25, so 50 plus 25, so 75% drug gets eliminated. After third half-life, 50% of 25, that is 12.5% plus initial 50 plus 25, so total 87.5% drugs eliminated. After fourth, 93%, and after fifth, around 97% of drugs get eliminated from the body. So for an example, if drug X is having a half-life of 10 hours, what is its clinical significance? Its clinical significance is it takes around 50 hours for that drug to completely or nearer to completely go out of the body. And what if the drug Y has a half-life of 3 hours? So this drug will get eliminated from the body within 15 hours or so, right? So this half-life is mainly required to determining the dosing frequency, how frequently we need to administer the dose. So for that, this plasma half-life is very important thing. Now there is formula of half-life as well, that is 0.693 into volume of distribution upon clearance. So if you've been given a figure of volume of distribution, if you are given a figure of clearance, you can now detect the half-life of that drug. So half-life depends upon these two as well, volume of distributions and clearance. From that, let's discuss two important terminology in dosing, that is loading dose and maintenance dose. Now let's take an example, practical example of this loading dose. In malaria, generally doctor prescribe the drug name as chloroquine. Now how it's been prescribed? The doctor will ask you to take 2 or 4 tablets initially. After 12 hours, take 1 tablet. After 24 hours, take one tablet. Again, after 24 hours, take one tablet. So this is a kind of a schedule which is been formed in this treatment. Here the important characteristic is this. Why initial high dose? Why initial high dose is been given? This dose is called as loading dose, right? And this loading dose has an important aspect in it that is called as volume of distributions. We have seen some of the drugs binds less into the plasma proteins but have high affinity to the tissue proteins, so they goes in a higher concentration into the tissue. So these are called as high volume of distribution drugs. So they remains less into the plasma, goes to the tissue proteins and binds to them. So these are called as high volume of distribution drugs. So in this case of malaria, where we need higher concentration into the blood, so what should we do? So we initially give high dose of drugs so that all the tissue protein gets saturated. And now we are giving the drug so that the drug concentration into the blood increases, and that is therapeutically beneficial for us. So that is a practical example of loading dose. So we are giving loading dose at the initiation of therapy to attain the target concentration rapidly. It saturates the tissue proteins. So loading dose mainly depends on volume of distributions. And maintenance dose means we need to maintain the concentration above therapeutic level for longer times. So that is mainly decided by clearance of drug, how quickly it gets cleared or how much time it takes to gets cleared. Okay, so depending upon that, we can decide the frequency of dosing administration so that the level of drug concentration remains above the therapeutic level. So that is loading dose and maintenance dose.